That for metastatic urothelial carcinoma, the previous era based on the cisplatin eligibility or ineligibility, the options first time were platinum-based chemo followed by taxanes or immunotherapy. So if the patients were ineligible, they would go directly to taxanes. And in the current era, it's the same. And if the first line remains the same, the platinum-based chemo, and the second line or maintenance will be immunotherapy, and the third line might be the Nectin-4 inhibitor enfortumab or the FGFR3 2 inhibitor edafitinib. So the role of immunotherapy, so the maintenance setting, switch maintenance, that is the patients who have been given chemotherapy and after cisplatin-based chemotherapy, for example, the study based on gemcitabine plus cisplatin. So after 4 to 6 cycles, if they are having a maintaining a response with a partial or complete, then immunotherapy can be given as a maintenance, and this will help prevent the recurrence and improve the OS. So for this setting, the trials are the HCRN 14182 is the phase 2 study of pembrolizumab and Javelin Bladder 100 study of pembrolizumab. So this is a phase 2 study, and based on this study, the dose of pembrolizumab 10 mg per kg or 800 mg flat dose given 2 weekly versus best supportive care after initial chemotherapy. So you can see that there is an improvement in the OS, which is statistically significant. So based on this improvement in OS, it is a approved treatment, and we are using it in almost all of our patients who are eligible and affordable for the same. So in the first line setting, now for immunotherapy, the following questions are there. Is there a role of chemo plus immunotherapy? Is there a role of immunotherapy alone upfront? And is there a role for biomarker selection for immunotherapy? So, so that studies are done for the various immunological drugs available, immunological drugs available. So, in the first group of studies, IMvigor 130 for adjuvant, Keynote 361 for pembrolizumab, Checkmate 901 for nivolumab, and in the PD1, PD-L1 plus CTLA4 inhibitor. So, Danube study for durvalumab plus durvalumab, and Checkmate 901 mainstream Nivo plus VP was done. So all these patients, the question was that whether the upfront patients, whether eligible or ineligible, whether they were randomized to either alone, immunotherapy alone, chemo plus immuno, or chemo alone. So in these studies, there was very minor improvement in PFS on addition of immunotherapy to chemotherapy, and it was not very significant, and also the OS there was no significant improvement. So based on these studies, currently immunotherapy plus chemotherapy is not preferred to chemotherapy. Now only for patients who are ineligible for any platinum, those patients will go for immunotherapy. So the role of immunotherapy alone. So again, based on these studies, you can see that compared to the immunotherapy alone arm versus chemotherapy, again there is not much significant improvement in all the studies for various durvalumab, pembrolizumab, and atezolizumab. So again, the role of immunotherapy alone upfront remains only the patients who are platinum eligible. Now the third question is the role for biomarker selection for immuno-oncology? So again, we know that for different drugs, different companion diagnostics are approved, and for different in these settings, the having a common benchmark for percentage of PD-L1 positive remains elusive. So, so again, based on these studies, we can see that definitely there is some improvement in the OS compared to the PD-L1 population, but the thing is that other than the patients who are PD-L1 negative, other than that benefit is seen. So although benefit is more in PD-L1 positive, but benefit is also seen in PD-L1 negative patients. So in all these studies, the percentage of patients who are PD-L1 positive were around 50%. In some studies, it is less than around 24%, but still benefit is derived. So again, the question of whether the role of anti-PD-L1 plus CTLA4 is there in some studies like Checkmate 90 and Danube study. So again, in this studies, the addition of two drugs compared to chemotherapy, although it increases the overall response rate, but it doesn't translate into OS or PFS benefit. And again, we have the new drug, enfortumab vedotin. So, where does this fit? So, in the patients who are suspected ineligible, with this combination, a very good overall response rates have been seen. Even some patients, you can see around 50% of patients went into CR rates. So, these data is even better than chemotherapy. That's why this is being explored in the phase 2 and phase 2 studies, so that it might replace, it might be a replacement for chemotherapy based on the higher response rates. Summarizing for frontline immunotherapy, the post-response to initial platinum-based treatment, nivolumab maintains the approved indication and it should be used. For platinum ineligible, pembrolizumab has the best data, and it can be used with or without enfortumab. But since the data for enfortumab is very basic phase 1b, phase 2 data, and phase 2, phase 3 study going on, so currently for only in this indication it is not cannot be given, but it's FDA approved for certain indications. Also, atezolizumab was given accepted approval along with pembrolizumab, but with the recent data of the phase 3 studies, the OS data is not showing significant improvement. So the makers have voluntarily withdrawn the FDA approval. And now coming to the platinum refractory setting in the second line. So all of these drugs, you can see all of the high-level immuno-oncology drugs have been approved in the platinum refractory setting post progression. So, but you can see that the common thread is that the overall response rate remains in the range of 50 to 20%, whereas the response rate in second line therapy apart from immunotherapy was around 10%. So this 5%, around 5% benefit was seen, and the median OS also remains in the range of around 8 to 10 months for most of them. For durvalumab, in one study it was seen around 18 months, and the median PFS also remains in the range of 2 months. So based on these all studies, they have been approved. But since you can see that only for pembrolizumab we have phase 3 data, so if we have to use any one drug, pembrolizumab will be preferred drug. And in the new and the adjuvant setting and the new adjuvant setting, it's already been discussed, so I'll skip this. And one more thing, with the use of immunotherapy, you should always remember that the potentiality of adverse effects, new spectrum and unknown, or maybe not many of the oncologists or other specialty will not be aware of managing them. So you should remember that since there is an immune infection, so all the organs can be involved, and so you should have a lookout for all the possible immune-related adverse effects. And in most of the cases, for the mild adverse effects, not much is required. But for moderate, we might have to hold immunotherapy and we might have to use steroids, and so this might be, if there is no response, then we might have to stop. So all these things have to be borne in mind. Thank you.
Thank you, Dr.